We're thinking now about management principles in burns and how we can prevent the complications that are associated with burn injuries. Now, the risk of systemic complications increases with the percentage of surface area involved and with the thickness of the burns. The deeper the injuries, the more significant the risk of systemic complications. And burns which affect large areas of the body surface area, say over 40%, carry very significant risks of systemic complications and even death if they are not properly managed. And other injuries can make burn injuries more difficult to treat as well. For example, if someone's had smoke inhalation injury or other concurrent injuries, for example traumas from a fall, then also there's an increased risk of mortality, and it makes the management of these patients more complicated. Also, the very old or the very young are more prone to complications and mortality after burn injuries. Indeed, people even over the age of 60 or below the age of 2 are at greater risk. Now, I think probably the first systemic complication that comes to mind when anyone thinks about burn injury is hypovolemia. Now, normally, of course, the skin forms a waterproof layer over the surface of the body. And if this waterproof layer is disrupted, then water can simply evaporate out of the surface. That's one way that water is lost after burn injury. And inflamed skin weeps plasma into the wounds. And burns, of course, cause massive inflammation. So there's a lot of exudate, inflammatory weeping of plasma into the burns. And of course, as well as losing water, because it's plasma, protein will be lost as well. So there's a risk of hypovolemia and hypoproteinemia developing as a result of the weeping of inflammatory exudates into the wounds. After burns, there's a lot of edema can develop as well. Burns can be associated with very, very significant edema. Deeper burns, the edema can form underneath the burnt tissue. But of course, if the fluid forming the edema is in the tissue spaces, it's no longer in the blood, and therefore it's reducing the volume of the blood. And fluid loss will lead to systemic features such as dehydration and thirst. Burns patients are usually very thirsty. Hypovolemia can develop, and of course that means that potentially hypovolemic shock is a risk factor. And hypovolemic shock is associated with other complications of its own, of course, such as renal hypoperfusion and renal failure. And as well as that, it's reasonable to assume that hypovolemia is going to lead to a reactionary peripheral vasoconstriction. And that's going to reduce perfusion of the burn itself, and that's not going to help the healing, because for a wound to heal it needs a good oxygen supply and it needs a good blood supply. Now, if patients are showing clinical features of shock, or in an adult if there's more than 15% of the body surface area has been burnt, then they're going to need intravenous fluid replacement. And children will need intravenous fluid replacement with smaller surface area involvement. Children will normally need intravenous fluid replacement if there's 10% of the body surface area or more involved. And this is because children have a large surface area in relationship to their volume. Typically now we'd start by giving a crystalline fluid such as Hartmann solution, and that could be given for the first 24 hours. And there's various formulas that are available for calculating the amount of fluid that's required. The Parkland formula is probably the most commonly used one in the UK. But these are only a guide. Fluids need to be titrated according to the patient's physiological requirements. And one thing that we must ensure is that all patients are producing at least an absolute minimum of 0.5 mils of urine per kilogram of body weight per hour, and preferably we would like to see nearer 1 mil of urine being produced per kilogram per hour. And in children we certainly want to see 1 ml of urine being produced per kilogram per hour. And of course, whenever there's fluid imbalance, we also want to check on the electrolyte balance, because fluids and electrolytes should always be considered together. Now, we mentioned that patients are very thirsty after burns, but sometimes burns can lead to a paralytic ileus. And it's worth checking if there's a larger surface area of body surface area has been burnt, to make sure that the gut is working properly before we start giving these patients large volumes of fluid to drink. It might be necessary, if there is a paralytic ileus, just to rehydrate the patient intravenously until the gut starts working again. I think we'll say something specific about electrolyte balance actually. Whenever there's extensive tissue damage, then the cells are going to be damaged as well, and cells are going to be killed. And that means the cell membranes of the cells are going to be killed as well. That means the cell membrane can no longer compartmentalize the cytosol of the cell. And of course, in the cytosol of the cell, in the intracellular fluids, there are high concentrations of potassium, as opposed to relatively low concentrations of potassium in the extracellular fluid. So if a lot of cells are disrupted, that's going to release a lot of potassium, and that can cause a hyperkalemia, an increase in the amount of potassium in the blood. Now, as long as the kidneys are working properly, they're very good at excreting large amounts of excess potassium if they need to. But if there's acute renal failure complicating the burn, and the patients aren't producing urine normally, then serum potassium levels can rise significantly. And of course, if you have an acute hyperkalemia, that's got potentially serious cardiac complications, such as ventricular fibrillation. So do monitor electrolyte balance, do consider it, especially if the patient is developing an acute renal failure. The next complication I want to talk about is protein loss. Now, we've said that plasma exudes into burnt areas and that there's protein in the plasma. The main protein in the plasma is albumin. So albumin and other plasma proteins can be lost from the plasma, from the blood, into the inflammatory fluid which weeps into the wounds. And this can reduce the total amount of albumin in the plasma. In other words, it can cause a hypoalbuminemia. And if we give patients a lot of crystalline fluids as well, this can dilute the albumin which is already present in the plasma. Now, if we have less albumin in the plasma, that's going to reduce the osmolarity of the blood. And that means that the tissue fluid is not being actively osmotically reabsorbed at the venous end of the capillaries. And this can make the edema, which is already associated with burns, worse. So the hypoalbuminemia can exacerbate the hypovolemia, because the hypoalbuminemia will allow more edema to develop. And of course, if the fluid is in the edema, the fluid is no longer in the intravascular compartment. Therefore, blood volumes will be reduced. Next, I want to talk about pain. Now, burns are extremely painful injuries. Superficial burns can be incredibly painful, and the most painful of all are shallow partial thickness burns, where there is exposed nociceptors, the pain receptors in the dermis. Extremely painful injuries. So don't hesitate to give these patients the full force of analgesic therapy. In the first aid situation, in transfer to hospital especially, Entonox is quite a useful preparation. 50% oxygen, 50% nitrous oxide. The patient can self-administer it. If they're holding the mask on themselves and they take too much, the hand will fall away, the mask will fall away, and they'll start breathing air again, and they'll start waking up. So Entonox is very useful in that sort of situation. And in hospital, don't hesitate to give these patients intravenous opioids. They will need intravenous opioid-based medication. And burns are also very distressing. They cause a lot of anxiety. So make sure that you use the full powers of your empathetic and interpersonal skills with these patients to reassure them, because the pain causes anxiety and distress. Let's talk now about the acute edema caused by the burn injury. As we've said, burns cause massive inflammation and there can be a lot of edematous fluid leaking into the tissues. This can obstruct the upper airways if there's been any inhalation of hot gases, but even if not, the mouth, the lips, the necks of the patients can become very, very edematous. So much so that it might be impossible to intubate these patients. And that might necessitate the patient having a tracheotomy, a surgical formation of an opening directly into the trachea. In an emergency situation, that could involve a cricothyroidotomy, an emergency opening through the cricothyroid ligament just below the thyroid cartilage, just above the cricoid cartilage. The other complication is that fluids can accumulate below eschars. Remember, if you have a deep burn, you get this layer of dead tissue over the surface called an eschar. And the edematous fluid can collect under this layer of dead skin. And as more and more edematous fluid collects there, the pressure will increase more and more, and eventually this can close off blood vessels. So in a Lympha example, the edematous fluid collecting below the eschar could cut off the blood supply to the limb, necessitating future amputation of that limb. Fluid collecting around about the abdomen and the chest can inhibit normal ventilatory movements. And if this is the case, then the dead tissue needs to be incised. Long cuts need to be made in it to relieve the pressure. And this procedure is called escharotomy. And although it looks very dramatic, this procedure actually won't be painful because the eschars are dead tissue, and when you cut into them it won't hurt. If it does hurt when they're cut into, then the procedure is probably not indicated in the first place. Actually, even though these incisions look dramatic, they won't increase scar tissue formation, because the tissue is dead anyway. Now, smoke inhalation injuries and burns often present in the same patient. And any patient who has been removed from a smoky environment, we need to monitor them for the possibility of smoke inhalation injury very carefully. We have to have a high index of suspicion because complications can develop after the patient has been admitted. Inhalation of hot gases can lead to thermal injuries in the upper airway, particularly affecting the epiglottis, and this can cause stridor and possible obstruction of the upper airway. Also, the patient won't be able to swallow, and they might be just drooling saliva because the epiglottis and the pharynx is inflamed. Now, if the airways are swollen as a result of edema, inflammatory edema collecting in the upper airways, the patients might need steroid drugs, corticosteroid type preparations, to reduce the inflammation and therefore to reduce the swelling. Other patients might need a tracheostomy to be formed to keep the airway open. Now, as well as the pure heat of the gases that the patient might have inhaled, they can inhale toxic substances from the smoke as well. So whatever's burning is going to give off some sort of toxins. Furniture foam, for example, can actually give off cyanide, which of course can cause death at the scene. So poisonous gases will be inhaled into the lungs if the patient has been in a smoky environment. And these poisonous gases tend to damage the lower airway. So the hot gases tend to damage the upper airway, and the poisonous gases tend to damage the lower airways. And these predispose to the development of pneumonia. So we need to monitor patients very carefully after they've inhaled smoke to make sure that they're not developing pneumonia. If they are developing pneumonia, we need to recognise this and we need to treat it fairly aggressively at an early stage. Smoke inhalation can also mean that the patient's inhaled a lot of carbon monoxide. carbon monoxide will combine with the hemoglobin in the blood to prevent that hemoglobin carrying oxygen. The combination of the carbon monoxide and the hemoglobin will form carboxyhemoglobin, which is a stable compound, meaning the blood cannot carry the oxygen. And one of the things about carbon monoxide poisoning is that it is not detected by pulse oximetry. So you can have someone who has oxygen saturations of 99% on the pulse oximetry meter, but actually they haven't got those levels of oxygenation in the blood because the oxyhemoglobin and the carboxyhemoglobin are registered in the same way by pulse oximetry machines. So if a patient's inhaled carbon monoxide, we cannot trust the pulse oximetry. It's one of the occasions where pulse oximetry lets us down and doesn't work. Now, renal involvement is a risk in burns, of course. Any condition which causes hypovolemia can cause an acute renal failure. Rhabdomyolysis is another possible complication. If muscle has been damaged or burnt, then it will release myoglobin, and that will cause a myoglobinemia, and that myoglobin can clog up the nephrons in the kidney, leading to an acute renal failure. If a lot of blood has been damaged as well, if the blood has been burnt, that can cause the release of myoglobin into the blood, and myoglobin can also clog up the renal tubules. Another recognised complication after burns are stress ulcers. Multiple gastric erosions or duodenal ulcers can both develop. These are probably explained by the reduction in blood supply to the gut as a result of a sympathetic compensation after the burn injury. The development of these ulcers can be somewhat curtailed by starting to feed patients at an early stage, and we often give these patients intravenous ranitidine as well, prophylactically, because we know that these ulcers are likely to develop. Now, after a burn, a patient has an increased nutritional requirement. Burn injuries cause massive catabolism throughout the body. So to compensate for this, we need to give lots and lots of extra nutrients. And as well as the catabolic effects, the patient is going to need lots of extra nutrients in order to heal these large wounds. So they're going to need plenty of carbohydrates to make the energy, and they're going to need plenty of proteins to regenerate the new tissue. So a patient with a significant burn injury might need twice as many carbohydrates and proteins as they normally would require. They'll need a high-calorie diet during the recovery phase. Now, wound infections are very common after burns, so we need to be meticulous about the way we care for the wounds. So in the acute situation, burns should probably be washed with soap and water to remove any debris or superficial foreign body. And any devitalised tissue which can be readily removed should be removed. Larger blisters will often be removed, but smaller blisters should probably be left. A common approach to preventing infection is to use flamazine, silver sulfadiazine, and that is spread over the wound and then covered with a sterile dressing. An aseptic technique here is absolutely vital. And these burns all need to be dressed daily or even twice a day so that the condition of the burn can be checked on, that any devitalised tissue can be removed, and more antibacterial ointments can be applied. As a general principle, prophylactic antibiotics should probably not be given, as these can give rise to superinfections. But if there is any overt wound infection, then antibiotics should normally be given at an early stage. If there's any necrotic tissue present in the wound, this significantly increases the risk. Because bacteria can live in the necrotic tissue, it provides a habitat, and it also provides a food supply for them, so they've got somewhere to live and all they want to eat. So necrotic tissue is very likely to become infected. And as well as that, the body's immune system, the body's immune mechanisms such as macrophages can't operate in necrosed areas. The white blood cells cannot migrate through necrotic tissue. So once established, infection will rapidly migrate from the necrotic tissue into the healthy living tissue, and that can overwhelm local defences. This is called burn wound sepsis, and it is a life-threatening condition. Burns are at serious risk of infection. And with deep burns, where there's eschars, there's a massive risk of infection. So most burns units will surgically debride these sheets of dead tissue to get rid of them. Otherwise, they are an absolutely rampant infection risk for the patient. And once they've been removed in a burns unit, they can put on skin grafts to close the wound. And that massively reduces the infection risk and very, very significantly improves the prognosis for the patient. So keep a very close eye on these patients for the clinical features of systemic infection and local infection. I think the last complication I'll mention, although we could do many more, but the last one we'll do today is scarring and joint contractures. Now, deep burns cannot heal by regeneration of the skin tissue. This means that without skin grafting, they can only heal by granulation. And if they heal by granulation, there'll be a lot of scar tissue formation. And once scars are formed, they start to contract because they contain fibroblasts and myofibroblasts, which contract in the weeks and months after the scar has formed. And this will result in very tight scars and contractures. And this can result in complete deformity and immobilization of hands and feet and joints and serious disfigurement. Contractures around the thorax can inhibit ventilation, and contractures around limbs can lead to congestion and ischemia of the limbs. So therapies need to be aimed at the prevention of scar contractures, and these are most effective if they start early in the healing process, when the scar tissue is still pliable, before it contracts and before it hardens, and before it hardens, and before it hardens.